Very good. Well, thank you, Anthony Quinn, for being the background to this webinar today. And we really appreciate everybody who has tuned in. Welcome from right across the country, literally from coast to coast. We're happy to have you all here today. As Anthony has already mentioned to some of you, this event is being recorded. So if you want to share it or send it to friends and family, you'll be able to. We'll be sending everyone who is registered a link. We'll also be posting it on our carp.ca website and on our social media. So you'll be able to see the webinar at any point that you want after today. We're very pleased to have with us today Dr. Ajit Johal. Dr. Johal currently practices in Vancouver, BC, and he's been providing immunization and clinical education for the last more than a dozen years. As a community pharmacist, he's also a provider of immunization to patients in the community. And in 2018, he started an organization called immunize.io. And its mission was to take the best shot at immunizing the world. And through immunize.io, he's worked with numerous organizations in the communities to address vaccine hesitancy and to improve vaccine access. Dr. Johal is also a clinical assistant professor at the University of British Columbia, Faculty of Pharmaceutical Sciences program. So with that introduction, I'm pleased to introduce to you Dr. Ajit Johal.
Well, thank you so much for the introduction, Bill. I have to say that's one of the best reads of my bio that I've ever heard. So thanks for that. And thank you to all of you for tuning in, and thank you to CARP for having me today to talk about this really important topic of shingles and vaccination and how to prevent terrible complications from this disease. So as Bill mentioned, I am a clinical pharmacist and do work part-time at the University of British Columbia. And I also lead a not-for-profit organization and a national initiative called the National Vaccine Center of Excellence program, where really provide a lot of awareness, education to both patients and healthcare providers about what I like to call immunization corridors. You know, is a vaccine recommended? And then, of course, you recommended me this vaccine, and I want to protect myself from this terrible disease, but how do I access it? So that's really going to be the backbone of today's presentation. And today's presentation will be short, so we'll allow a lot of time for Q&A. And I can see there's already some questions already appearing in the chat. So hopefully I've had a sneak peek at them. So hopefully I'll try and address them in this first round of the presentation. But if I didn't address your question, feel free to ask it in the Q&A. So at the university, they do make us instructors make learning objectives for our presentations. So this is the formal, what we call Bloom's taxonomy that academics use to build learning objectives. But because we want to keep it short and simple and to the point, there's four things that I'm going to highlight in this presentation. The first is, the reality is our population is aging and we need to rethink our healthcare system priorities. And I'm sure CARP will be in full agreement with this. The second is shingles contributes to significant quality of life reduction in adults. And that is really important because as we are seeing people live longer, we want them to live healthy and fulfilling lives. And shingles, the mortality is quite low, but the morbidity, so morbidity means, you know, your quality of life reduction, the suffering is quite high. So that actually, when we look at statistics, that's even more impactful than mortality. There's also an effective shingles vaccination to prevent disease and complications. And finally, the million-dollar question, well, I'm going to say probably the $330, $350 question is, how do you get the shingles vaccine? So I wanted to start with this setting the scene because this really anchors why we need to prioritize vaccinations for older adults in terms of recommending them, in terms of chronic disease management, but also having more programs. Just like we have for neonates and infants and adolescents, we need to have more vaccines covered under public programs for adults. And the fact of the matter is our population is changing. People are living longer, and a lot of that actually has to do with vaccines and other sort of interventions like cleaner sanitation and drinking water. But we're seeing the average life expectancy increase dramatically as we see the decades move on. Canada is, of course, seeing this massive population boom where the number of individuals over the age of 65 in the next 20 years, and this has already started because we're already almost 10 years into this population boom from 5 million to 10 million in this country. And of course, individuals living longer, if they're over 50, if they're over 60, are also living longer because we're managing chronic diseases. So that means they're living longer and they're living with diabetes, COPD, asthma, heart disease, all of which increase the risk of complications from vaccine preventable diseases. And we take all of that knowledge we know of what's happening, and we pair it with the reality that as we age, our immune system ages with us. And that, of course, you can eat healthy, you can quit smoking. Those are excellent interventions, but your immune system always will decline with age. And that's why, when we're infants, we're seeing our immune system build up, so we're more vulnerable. And then as we get older, it peaks and then it drops. And as we get older, we have less T cells and we are more susceptible to infections and complications. So that's why we need more vaccine recommendations for these approved and strong vaccines that we have seen in recent years for older adults. So that kind of sets the stage and brings us to shingles, which is one of those vaccine preventable diseases that is recommended for older adults. So shingles, how does it happen? So from left to right, it starts with a primary infection from varicella zoster virus, also known as chickenpox. Chickenpox, very contagious. We've heard about chickenpox parties where kids would just let them get chickenpox. So 95%, maybe more of Canadian adults, especially those before who are over 50 at this point in time. The chickenpox vaccine was rolled out in the early 2000s, but most Canadians have been exposed to the chickenpox virus. And the question I get is, well, I don't remember if I had chickenpox as a kid. Well, you may or may not have had symptoms. So the exposure to this virus is very high because it's extremely contagious. So just to give you some perspective, and the reason why parents had chickenpox parties is one is you can get immunity to chickenpox by getting the actual virus. It's better to get it earlier in life. I mean, obviously it still has complications, but it's very contagious. So one person can infect 12 to 14 other people with chickenpox. So it's extremely contagious. And then people get the spots, or maybe they don't. And then it forever just kind of lays dormant. So it's not quite gone away. So that primary infection is actually now become a latent infection. So the virus remains dormant in a part of your spinal cord called the sensory neuron. So it kind of stays there for a period of time, and then it has its sort of second coming or reactivation, which is due to stress, could potentially due to underlying medical conditions. But for most people, we see this, and globally we see this, that after the age of 50, we start to see reactivation. So age, that diagram I showed, as the immune system declines, it fails to keep this in check. And then the virus reactivates differently than when its primary infection was, is because it lives in the dorsal root ganglion, it's going to go across what we call the dermatomes. And dermatomes are sections you can see in this diagram, sections of the body that are innervated by different nerves, different parts of the skin. And these sort of patches depends on where the virus comes out of the nervous system. And it doesn't cross the midline, so it's typically one side, and then it leads to this sort of painful blistering rash. And if you're unlucky, of course, anybody with shingles is unlucky because it's painful, it's debilitating. But if you're especially unlucky, it can actually come into the cranial nerves here, which do the head, neck, and eye. So there's actually shingles that can actually come across the eye, which is an ocular emergency, potentially leading to a loss of vision. And even on top of that is individuals who have cranial nerve shingles reactivation actually have a increased risk of future stroke. So definitely not a benign disease. And the lifetime risk, which many of you might be unaware of, is 1 in 3 after the age of 50. That increases every day you get older than 50. So the risk is higher for those in their 70s or their 80s, but across the lifespan, as soon as someone turns 50, they have a 1 in 3 chance of developing shingles. And then, of course, 1 in 17 patients, so less than 1 in 20, will have recurrent episodes. So again, it is certainly possible to have more than one case of shingles in your lifetime. Reactivation again and again is possible. So that's sort of the shingles story. And then, of course, for those who are especially unlucky, typically 1 in 10, 1 in 9 cases of shingles, the nerves just don't quite recover. So there is some lasting neuropathic pain, some shooting, burning, stabbing pain, allodynia, so that's basically cold sensitivity, and hopefully that goes away after a couple months. But in those patients with post-hepatic neuralgia, so that is after 3 months, they're still having this pain from a previous shingles infection. That's called post-hepatic neuralgia, and that might actually last indefinitely. So this is some statistics that I often find helpful to illustrate the burden of shingles. So shingles can happen certainly to healthy people, right? You can eat healthy, you can exercise, and then after the age of 50, you may not be taking any medications, but then you get hit with shingles, and the data shows that those who are on 0 medications before they got shingles all of a sudden are now taking 4 or 5 medications. And what are those 4 or 5 medications? Well, the first is a blue tablet called valcyclovir, which is an antiviral, which hopefully you can get within the first 48 to 72 hours when you start to see a rash. Timing is important. Although it may treat it quicker, it doesn't prevent complications. The second is if the rash becomes infected, you might need to take an antibiotic for gram-positive infections called cephalexin as an antibiotic. And then the other 2 to 3 after that would be if you develop complications or post-hepatic neuralgia, pain management. So things like gabapentin, amitriptyline, all of these sort of nerve blocking medications, which have a lot of side effects, unfortunately. I'm a pharmacist, so I know the side effects of gabapentin can include swollen ankles, drowsiness. Amitriptyline can be very drowsy, cause a lot of sedation, falls, urinary retention, and things like that. So that's where these medications come from, is 0 medications, life was going along great, no problems, no issues, and then bang, 4 to 5 medications to deal with infection and then eventually pain control. So quite a astonishing statistic, to say the least. And then, of course, the ability to work. I find this interesting because after the age of 50 is when the vaccine is recommended, because that's when we see an increased risk of reactivation. Statistically, that's where we start to see this inflection point. And a lot of individuals between 50 and 65, maybe even older, are working individuals. So that'll kind of spiral into what I talk about why employers should cover this vaccine. But it leads to significant time off work. Significant time off work to deal with the initial infection. The infection, the lesions, the rash, and the vesicles of shingles cannot cause shingles in another person directly, but they can cause chickenpox in somebody who might be at risk. So a common story I give is for my cousin. She had twins a couple years ago, and her in-laws were taking care of them. Her mother-in-law developed shingles, and the fear was transmitting that shingles to the newborns who are unvaccinated against chickenpox. So it certainly causes some issues. Individuals with shingles should not go to work. They should take the time to recover. They might have to go to different doctors or specialists for different medications. They certainly will have to go to the pharmacy for at least 1, maybe 5 medications, but it leads to a significant time off work. And then, of course, we can't put the onus just on money in terms of lost employer costs, lost productivity costs. What about the individual patient? And this is a great survey which looks at the quality of life in those who've had shingles versus those who hadn't. And in every single domain, individuals with acute shingles, complicated shingles, and of course, I talked about post-hepatic neuralgia, which is the neuropathic complication, score significantly lower in their functional, social, and mental health. So it's quite the impactful disease. And I always use this study because as we start to see individuals who are older adults, what they fear more than death is actually disability. They fear stroke more than death, because death, you're gone, you've lived a good life. But if you have a stroke, you lose your independence, you lose some of your functions, and people have to take care of you. So that morbidity is a high value point for older adults. And that's the whole thing, is adding good health adds life to years, not just years to life. So you really want, if you're independent and you're doing things, you're taking, playing with your grandchildren, you're taking trips, you're traveling, lifting luggage into a suitcase, into the overhead bin, all of those things, which are great activities. These types of diseases like shingles can put a damper on that, and that damper might be irreversible. So we need to do what we can to prevent that, which is a great segue to there is an effective vaccination to prevent disease and complications. Bit of a busy slide, but what I want to highlight here is this vaccine, what we call the recombinant zoster vaccine, which is 2 doses. The brand name is Shingrix at 0. So there's one dose, and the second dose at 2 to 6 months. Is recommended for everybody over the age of 50, and that's a strong recommendation by the National Advisory Committee on Immunization, also known as NACI. So everybody over 50 should have this vaccine. It's considered sort of this standard of care. Individuals who've had chickenpox vaccine may still be susceptible. Individuals who don't remember if they have chickenpox may be still susceptible, and they should definitely get the vaccine. No need to do serology or blood work. It's not really predictive of anything. And then history of shingles. We saw one question in the chat. I've had shingles once or twice. Is it still worth it to get the vaccine? Absolutely, because when we get shingles and our body makes antibodies when we're not vaccinated, they're not very good and they don't last long. So if it's been a year after you've had shingles, or some other guidelines say you could do it sooner as long as you've recovered, it's recommended to get the vaccine. And then some of you may have gotten the older shingles vaccine, the Zostavax, which was great at the time, but it's not as effective as the 2-dose Shingrix vaccine. So individuals who've gotten the older vaccine, the Zostavax, should get the 2-dose Shingrix vaccine. I always talk about this sort of durability. And I think what's really great about the newer shingles vaccine is I tell my patients when I provide the vaccine is that there's no booster recommended at this time. Now, it's really important that you get your second dose because that actually drives the protection up 17 times. So if you get 2 doses, it has been shown to be protective for at least 10 years. So that's fantastic. And there's ongoing data monitoring. And actually, when we look at what we call the correlates of protection, so the antibodies you make if you've been vaccinated, mathematically, we can model that out for 20 years. So it's very promising that it's going to be longer than 10 years, the protection from this vaccine. And that's really good news because as we get older, the risk goes up. And that was the concern with the Zostavax vaccine is as that protection went down, your risk of shingles still is higher as you get older. So very encouraging to show that this has really long durability. Side effects is something that, we definitely don't want to give patients, we want to give them realistic expectations, is that because it's difficult, your body doesn't do a good immune response and a long-lasting immune response. Naturally, we have to convince it to do a good job with the injection. And that means might feel a little bit icky for 1 or 2 days. So most patients will feel a sore arm, and that's typically more sore than other vaccines than you probably had. And then some patients, it seems about 3 to 4 out of 10, so 30–40% might get sort of fatigue, chills, feel a bit icky for 1 or 2 days. And I always tell people that's how we know the vaccine's working. And it's also predictable. So I say, you know what, if you want to take a Tylenol or if you don't have any underlying kidney issues, taking a Advil just to kind of make yourself feel a bit more comfortable. We know that duration is max 72 hours, and we can time that around that. So are we going to do shingles vaccinations before a trip or before before a wedding? No, but we have the flexibility to time it so that you can take those couple days and take it easy. You know what doesn't have that luxury is shingles disease. It kicks you when you're down, it strikes at the worst time. And people have gotten shingles, in my experience, before they go on that trip or before a big event, because that's just stressful, right? So it's important to let people know that there are some side effects, but they're short-lived and they're predictable, versus this disease is terribly unpredictable. And this is sort of the great, I always tell pharmacist colleagues to work with your patients to remind them to get that second dose, because if we look at these sort of T cells that are really important for preventing shingles long-term, they go up 3 times after the first dose, and then 1 month after the second dose, they go up 17 times. And really, if it's been more than 6 months, a year, or even 3 years from your first dose, just get that second dose. You don't need to restart. And that's something I always tell pharmacists, because the immune system will work in that way. It'll drive up the response when you get that second dose. So bottom line is 2 doses is key. And then on the left is Zostavax. It's no longer in circulation, but those who got the shingles vaccine, 10, 12 years ago, it's probably Zostavax. Those who've gotten it since about 2018 and you've gotten 2 doses, you've got the Shingrix, and you've got great protection for at least 10 years. This is sort of the effectiveness of the Zostavax, and as I was saying, it drops, and the Shingrix, it starts high and it stays high. Okay, so before we open it up for questions, and we're making great time here, you set the stage. You said vaccines are important as I age, and shingles is a bad disease, and there's a vaccine that's effective, it's safe to prevent it. So how do I go about getting this vaccine? And that is a really good question. So the first step is most of us are underestimating their shingles risk and the severity of it. So this was a national sort of polling study that was done for Canadians over the age of 50, where they didn't realize that their risk of getting shingles after they turned 50 was 1 in 3, and they didn't realize how severe post-hepatic neuralgia could be. So the first step is attending webinars like this, understanding what the disease is, what your risk is, and knowing that this is something that you should do. And this is some of the data from the poll. So the other thing is I want to talk about price. So the first step is you understand you're over 50 and you don't want to get shingles. You want to mitigate your risk. So there's certainly an opportunity to go out and purchase this vaccine. Now, this is a national webinar. Across the country, shingles is a Schedule II vaccine, so you don't need a prescription for it. You can go to a pharmacy, a pharmacist can recommend it and administer it for you. And the cost, although it ranges, is about, for each dose, it's about $170, $175 or so. It might be a little more or less depending on the pharmacy, but let's just say for argument's sake, it's about $350. So $350 upfront seems like a decent chunk of money. However, if you actually look at it in terms of your 10-year plan for health, because it has 10-year data, we're actually looking at $35 a year, maybe even less. So if you actually look at what are some things you could do in 10 years to be healthier than your former 10 years ago self, quit smoking for sure. And by quitting smoking, you want to sustain that. And that means even after 10 years, you don't pick up a cigarette again. Exercise is really good, 150 minutes of physical activity a week. I would argue that a gym membership is more than $35 a year. Some of them are probably even like rec centers at $35 a month. Eating healthy. Groceries are completely unhinged right now. They're super expensive, especially healthy food and produce. So if you actually look at your 10-year health plan, getting a shingles vaccine is extremely cost effective. So $350, and I even showed the mathematical modeling. That's just the return on investment just keeps getting better and better for this vaccine. And that's what I really like about these durable vaccines for diseases that increase as you get older. A good durable vaccine pays its dividends. Its return on investment is quite high. So individuals who have the finances to do so, it is certainly a valuable investment and intervention. And I recommend it for all of my friends, family, patients who are over the age of 50. There's also another indication for those who are under 50 but are immunocompromised. If you're immunocompromised due to a medical condition or taking a certain medication, your risk of shingles is quite high, and the vaccine is also protective for these groups as well. So that's sort of the first thing, is understanding the disease and understanding the vaccine is accessible and understanding there's value to it. Now, the other thing is $350 is a great way to spend health and wellness money. Why don't employers do it? So if the vaccine is recommended for 50 and over, that's a lot of working individuals. That's a lot of loyal working individuals. So I'm from the millennial generation, and we're not very loyal. So we change careers all the time. And a lot of these workplaces are really the sort of the drive and the thrust from it come from these long-term workers who are very highly trained, very loyal. And if they go down with shingles, there's no one to replace them. So I am seeing, and I do a lot of education for benefits providers, plan sponsors, employers, more and more benefits plans are covering the shingles vaccine. This is an example. I'm from British Columbia. The BC Teachers Federation, as of July 1st of this year, is covering the shingles vaccine for all of their BC teaching union members. What an excellent intervention, because if a teacher goes down with shingles, it's very hard to replace them. And again, because of the durability for the vaccine, it's a no-brainer in terms of an intervention that can have immediate impact. I always say, like a vaccine, 2 weeks later, you're more healthier than you were 2 weeks ago. No other intervention can do that. So employers should definitely be covering this vaccine. It's a no-brainer and it pays for itself and then some. Now, the challenge I see in my practice, and this is where the inequities come in. So the key to driving more awareness from politicians and to advocate for the vaccine is to highlight inequities. So those who have employers who are covering the vaccine should give the vaccine, and those who have financial means to get the vaccine should do so immediately. However, in this country, those who have a fixed income, it's a challenge to carve out $350. And to be honest, there are other vaccines too, like pneumococcal and RSV, and that really starts to add up. So that's where subsidies should definitely come in terms of covering these vaccines for individuals who are at risk for shingles and other vaccine preventable diseases. So this is a snapshot of Shingrix programs in Canada. I'm from British Columbia, so the only cohort that gets ministry coverage for Shingrix is those First Nation elders 60 years of age and older. They are covered under the FNHA Blue Cross plan. Ontario has a shingles program for those 65 to 70 years of age, so it's that cohort. The thing is, no jurisdictions have it covered for everybody over 50, but I think we should kind of understand where everybody's at and really find out how we can address financial barriers with targeted covered plans. And it's great to see a lot of other provinces and territories like Prince Edward Island picking up those, covering the vaccine for those over the age of 60. So that's sort of, we're seeing movement, but it's not quite there yet in terms of across the country having a publicly funded program. And on the advocacy side, I have advocated, I'm from British Columbia. This was a presentation I did for the BC Budget Finance Committee. And this is an open forum where individuals can talk about things that BC should fund. And I talked about the shingles vaccine, and I talked about the value, and I also talked about implementation. So a lot of times there's an announcement for a vaccine program, but unfortunately, and this is something I recently saw from the United Kingdom, and this is March 23rd, so a few days ago, is that they covered the shingles vaccine, but they didn't have enough supply, and they didn't kind of anticipate the demand. So they actually are doing this sort of, okay, they're prioritizing, they covered it for 65 and older, but now they're only giving it to those over 70. So those 66 to 69 are really upset because they said, well, you said you'd cover this vaccine and now there's none for me. So it's really important when I presented to the finance committee, it's not about paying the money for the vaccine. It's about investing in having enough, doing a scan of your demand, promoting the vaccine, and making it easy for people to get access to it. So it's all, that's sort of the way a successful public program would be rolled out. So that it made its way, it was published in the recommendations. So hopefully something we see covered in BC and hopefully other provinces as well. Now, the one thing I want to highlight is shingles is not the only recommended vaccine for older adults. There's a new RSV vaccine, and it comes at a cost as well. And experts in geriatrics, infectious disease are worried because that's going to lead to barriers in uptake. So at the end of the day, Andre Picard said it well, is we don't have a healthcare crisis, it's an implementation crisis. And instead of using a 1950s model of delivery and funding, we need a 21st century, and that is prevention. And he said we're driving an Edsel, and I didn't even know what that was. I didn't even know what kind of car that was. I had to look that up. But apparently it's a very popular car in the 50s, but we should be driving a Tesla. So with that, I want to highlight if cost is a barrier for you, and this is something that you feel that should be funded for older adult patients for shingles vaccination in your province or jurisdiction, check out the Advocacy Initiative through CARP. They have templated MLA letters that you can reach out to your local jurisdiction. So with that, I'm happy to open it up for questions.
Oh, thank you, Dr. Johal. That was certainly complete and follows very much the position that CARP has taken on the shingles vaccine. I wonder if you could just sum up before we get to the questions from Anthony. What if I was going to go to someone in my family and say, you should really get the vaccine? Can you give me just a short elevator pitch? Why should seniors be immunized against shingles?
For sure. So my elevator would go something like this. Shingles is a serious illness that can cause complications and impact your quality of life. The risk of developing shingles can be up to 1 in 3 after the age of 50. There's a safe and effective vaccine that can reduce your risk of the disease and complications, and I strongly recommend that you get this vaccine.
Good. Thank you very much. Anthony, over to you. I know there's a lot of questions there, so go to it.
Well, thank you very much. We've had over 420 people watching this webinar this morning, and terrific questions coming in. Doctor, you did predict many of those questions with your presentation, so thank you for being so thorough. But my first question I wanted to ask Bill about, and that's related to the advocacy. The doctor mentioned NACI and our strong recommendation. Can you just tell us a bit about how vaccines are chosen and what CARP is doing related to those NACI recommendations?
Yeah. Well, NACI is the National Immunization Committee. They're the ones that recommend to basically to the provinces what should be covered, and then it's up to the provinces decide whether or not they're going to take their recommendations. And often what we find is that, first of all, the provinces wait until they have the NACI recommendations, even though Health Canada may have approved the vaccines. But after that, then they begin making the decisions themselves, and it's a real checkerboard, as Dr. Johal showed on his slide of the different provinces, how many provinces don't cover it all. And some provinces give the impression that they do. Ontario, for instance, which many people think it's covered, and then find that it's only for a very small 5-year age group that are being able to be covered. So very much CARP's advocacy has been, this is something that should be covered for everyone. As Dr. Johal pointed out, $350 is a relatively small amount for the results that it gives, but for a senior on a fixed budget with all the increases these days, that's a lot of money to lay out at once. And we know that it would save the health system so much more money if they paid that $350 and didn't have to pay then the costs in treating shingles in following years. So this is a very strong part of our advocacy. And we're talking not only to the federal government, who we think should help the provinces do this, but to each individual province and say, if little old PEI can do it, then why can't you do it in your province too? My apologies to my friends next door at PEI, calling them little old. They're neither, but they are setting an excellent example for the rest of the country. And this is where, as the doctor mentioned, this is where you, the viewers, can come in. Because, we could talk from our national level all we like to government and say, you should do these important things. But, they really only listen when people who vote for them tell them. So what you need to do is tell your local elected representatives, both provincial and federal, but especially provincial, you want shingles vaccines covered. And you should do this in 2 ways. You should go online to carp.ca/shingles and fill in the letter that you'll be able to send, tell you exactly who to send it to there. But you should also phone or talk to, not send them an email. They don't look at emails that well. Phone or talk to your local representative, or at least his office or her office, and say, I want the shingles vaccine. And enough people do that, then it'll go to caucus. Caucus will talk to the ministries, and all of a sudden we'll get action. And that's where CARP's 225,000 members across the country can really have an effect on making this happen. Thank you for the opportunity to give the pitch, Anthony. Now back to regular programming.
Yeah, well, thank you very much. That's an important part of what we're doing. First comes the education on the topic, and then follows the advocacy. But back to the doctor. I guess one of the important questions, and there's many themes coming in, but who shouldn't get a vaccination for shingles? Who is likely not to be recommended by their doctor or their pharmacist to get a vaccine?
Yeah, so the vaccine is recommended for those 50 and over, and those 18 and older who are immunocompromised. So those who are 18 to 49 and they don't have any underlying conditions, the risk of shingles is quite low.
It was a specific question from someone who was on prednisone. So are there other medications that would prevent someone from having a shingles vaccination?
No medications that would prevent it. In fact, the common misconception that I see is there's individuals who are on medications like high doses of prednisone regularly, which is immunosuppressive. And if they have rheumatoid arthritis or Crohn's or ulcerative colitis, taking biologics, which also reduce the immune system and increase the risk of shingles. So if you feel that you're taking a regular medication that potentially is affecting your immune system, or you have questions about your risk of shingles, I strongly recommend talking to your doctor or pharmacist about that.
I believe you covered this, but someone, it was Grace, who said she has no family doctor. How can she get the vaccine? There are millions of Canadians who don't have a family doctor right now. Yeah. This is a role of pharmacists can play.
It really is the role of pharmacists. So wherever you live in Canada, in Alberta, pharmacists can prescribe. In BC, pharmacists can do all recommended vaccines as Schedule 2. In Ontario, the shingles vaccine is a Schedule 2 vaccine. And all of those, you do not need a physician's prescription. The pharmacist can assess it. Now, it depends if your pharmacist is comfortable doing so. If they don't, they should refer you to a pharmacist who is.
And a lot of people did take advantage of the Zostavax vaccine when it was out years ago. CARP was delighted to play an important part in having that funded by the Ontario government. And then when the newer, more effective medication came on, we were, again, advocating for that to be available to Canadians. But for those who have had the Zostavax, please go over again what they should do. And if someone has had shingles, what they should do.
Yeah, no, so definitely. And I think those who got the Zostavax, I think that's fantastic because we always have to evolve with the times, right? So in 2009, the Zostavax was the standard of care. It was either that or you take your chances with shingles. Now, with vaccines, we're seeing progressive iterations, and shingles is not the only one. For example, those who've gotten Prevnar 13 recommended to get Prevnar 20. So this is sort of it's great research and development that's happening to boost protection, but it's happening at a rate that governments can fund it, which is the problem. But to answer your question, those who've had the Zostavax, NACI, as Bill mentioned, the National Advisory Committee on Immunization, is recommending that those who've had Zostavax, 1 year later, they should get the Shingrix. And same thing of those who've had shingles, there's a risk of reactivation again. The immune response is not good. It's not as good as if you get 2 doses of that vaccine. So if it's been a year since your last dose of shingles disease, it's recommended that you should get the Shingrix.
And Bill, we've mentioned a couple of the other conditions that can be prevented by vaccines. What is those big five, the CARP?
Yeah, the big five that we believe all older Canadians should have access to, and we're asking governments to fund them, of course, are the COVID vaccine, the pneumococcal, the pneumonia vaccine, the shingles vaccine, of course, and the, I've lost the last one.
Influenza?
Yeah, influenza, yeah.
And the RSV.
And the RSV, right? Yeah. Now 5.
Now,
And
Bill,
I'd like to ask, just to follow up on that question, Dr. Johal. If you had the Shingrix vaccine when it first came out, how many years ago and when should, because we've got a lot of people of an age now who it's been a long time since they got that original Shingrix dose.
Yeah, so as I mentioned, the data for durability is quite strong. So we're at least 10 years and it's growing. So the shingles vaccine was out in Canada. We were giving our first doses in around 2018. So if you had your Shingrix early on, there's no need for re-immunization or boosters.
Good. Okay. Well, good. Thank you.
Bill, I saw you in the news when the federal Liberals and NDP had announced a framework for pharmacare, and you had an interesting suggestion on what they could do in the meantime.
Absolutely. The National Pharmacare framework that they have announced really only covers a couple of areas. It covers diabetes and birth control. And we said to them, look, if you really want to do something that'll help everyone right across the country and do it evenly and be equitable, and something that all the provinces said they'd like to do if they could afford it, then fund those 5 basic vaccines, and you'd have a real winner. They haven't done it yet, but we're still talking to them, and it's still at top of our request. We think it would be a lot easier and practically politically advantageous to them to do that funding rather than the kinds of things they're trying to do rather unsuccessfully right now.
Great point.
Some ongoing questions about side effects. You had mentioned the pain in the arm at the site of injection. What are some of the other things people should be perhaps concerned about when weighing the option of the shingles vaccine?
Well, I think I hope I made it quite clear that the risk versus benefit is very much in favor of the benefit of vaccination, far outweigh the risks. But we do want to be very transparent with potential discomfort that may happen post-vaccination. And usually I tell people, 3 out of 4 people might feel what we call systemic side effects. So that means, you might feel a bit of fever, chills, malaise for 1 or 2 days. But that's not serious and it'll go away on its own.
And what about someone mentioned Guillain-Barré syndrome, or are there any other more serious side effects that one should still want to understand going into making that decision?
Yeah, Guillain-Barré syndrome is a little bit of a tricky one because to define it, it's an autoimmune condition where the body's antibodies kind of attack what we call the neuromuscular junction, leading to some paralysis. It potentially has been linked to some vaccinations like COVID-19 vaccination, but it's extremely rare. Like we're talking like in the million, tens of millions of doses. And what I usually tell people is like, your risk of Guillain-Barré syndrome is actually 17. So influenza, for example, when we give flu shots, we say, there's a 1 in a million chance that you might get Guillain-Barré syndrome. There's a 17 in a million chance that you will get Guillain-Barré syndrome if you get influenza. So, a lot of these vaccines are actually protective against Guillain-Barré syndrome. The shingles vaccine, the linkage is not as apparent as some of the other vaccines. But again, risk versus benefits. There's no risk-free choice. But we don't want to fall victim of what we call the omission bias, where I'm not going to do anything, you're still putting yourself at risk of the disease.
In previous webinars, we've heard from physicians who have told us of the additional benefits of the influenza vaccine, in that it can help to prevent heart attacks and other conditions. Are there any additional benefits besides preventing shingles that the shingles vaccine could offer?
I'm glad you asked, Anthony, because that was right on cue. There's a lot of health benefits basically based on what the shingles virus can do to you. Now, I saw something in the chat saying I have 45% reduced renal function. Reactivation of herpes zoster can accelerate your progression from phase 3, phase 4 kidney disease to end-stage renal disease. Now, it's a similar way as influenza, this inflammatory response, the body doesn't quite know how to handle it. There's not a vaccine to coordinate, the antibodies. All of these chronic conditions, diabetes, blood sugars get more difficult to control once you've had shingles. Kidney disease, what we want for patients with chronic kidney disease, we want to preserve that kidney function. And that involves controlling your hypertension, controlling your diabetes, but avoiding shingles is right up there. And when we look at controlling sugars, controlling blood pressure, that's longitudinal. That's 10 years, 15 years. You got to take your blood pressure medications. You got to monitor your blood pressure because blood pressure will cause microvascular complications to cause issues with your kidneys. But imagine in that 10 years where you took your blood pressure medications religiously, you monitored your blood pressure with your machine, which you paid for, you got shingles, and that was all wiped. So it's quite powerful what we're seeing in the chronic disease space, what this infection can do, which again enhances the value of vaccination.
When Shingrix was introduced and the efficacy was so much higher than the Zoster vaccine, it almost seemed like we'd be able to eliminate or close to eliminate incidences of shingles. With a chickenpox vaccine now being given to children in their youth, will we see a time when this virus is no longer circulating?
It's a good question. Time will tell. Our cohort that we started giving the chickenpox vaccine to have not crossed the 50+ threshold. The challenge is, though, in other jurisdictions, and you'll see in actually the guidelines that even those who receive the chickenpox vaccine, and that's usually our immunocompromised 18 and up cohort, that they could still potentially get shingles, is why are they still getting shingles when they've been vaccinated for chickenpox? And it's tough to say, but one of the arguments could be is that they were exposed before they got vaccinated, because the chickenpox is a live attenuated vaccine. We tend to give that a little later to kids. So it's complicated, but it's something I think would be really interesting to see, that if we get high shingles vaccination uptake in our at-risk population and high chickenpox vaccination in our younger cohorts, and we see that over a period of time, I would think that we would see a reduction in the incidence of this disease. But unfortunately, we're only seeing an increase because we're seeing more and more people turning 50 who've been exposed to chickenpox and getting reactivated. So now is a really good time to roll out shingles vaccination to reduce the impact of shingles infection.
And I had one more question coming in as a general theme, and that was, or it was a comment mostly. People who know someone who have had shingles or have had it themselves, the pain and the suffering that goes along with it is enough to convince anyone to take advantage of this vaccination. Can you just talk a bit more about those symptoms of shingles and just how debilitating it can be?
Yeah, so I work on education and advocacy and to drive awareness for all types of vaccines. And when it comes to the burden of disease, the shingles one is often one that most people understand. Either they themselves have gone through it, or they've had a family member that's gone through it, or a friend or a neighbor. The disease presents very brutally, right? So it's like, painful rash potentially going up into the head and neck area. So I find a lot of people are aware of this disease and, the fact that, I've been meaning to get around to getting vaccinated. Life gets busy, right? So that's where we really need to prioritize this sort of preventative health behaviors in reducing your risk, because you don't want it to happen to you.
Thanks very much. I know that's what we hear most from members is that they've experienced it and they're very thankful this vaccine is now available. Bill, back to you for perhaps a last question and some closing remarks for the doctor.
Yes, well, I thank you very much, Dr. Johal. Very interesting, very complete. I don't have any other questions except to say that we will go over the questions that were in the chat, and if we find that there were any that weren't answered, then we'll put those answers out and let everybody know again that this session is being recorded. Will be available on our carp.ca website and on Facebook, where you will be able to find the link so you can watch it again or refer your friends to it. So I think I'll just finish up by thanking Dr. Ajit Johal, Anthony Quinn for your good work as always, Anthony,